From the title of this presentation, we'd be correct to infer that there has been a loss of relationship in the practice of medicine, and to restore it would be a good thing. And before I sketch out some of the evidence for this loss, why restoration is important, and how that might be achieved, I want to expound upon relationship as presented in a particular scripture passage and show that compassion is a necessary virtue to be evinced in the healing relationship. Mindful as we are of the feast in honor of St. Luke, it's fitting to call to mind one of his most well-known parables. Contained in Luke 10:25-37. How do I advance this? That one? This parable is viewed as a foundational scriptural passage for constituting an ethic of compassionate care. Indeed, it is frequently read and interpreted with the use of an ethical lens for Christian conduct to be shown especially to strangers and others for whom one may not otherwise care. The appellation itself, the Good Samaritan, popularly applied to this passage, suggests its moralizing content. And while this is a proper interpretive frame within which to reflect on the text and from which to appreciate its significance, it is nonetheless only one view. There are, of course, many others. For example, beginning with the early church fathers, an allegorical reading of the parable was common. Later interpretations emphasized this parable as a story of illustration or example for ethical behavior to be emulated by followers of Christ. Such a perspective today remains popular. Others have posited a view which emphasizes a soteriological dimension. The lawyer at the outset, after all, asks, "What shall I do to inherit eternal life?" In this presentation, I endeavor to show how yet another perspective, namely one grounded in a relational approach, offers a more comprehensive synthesis of the passage with respect to an ethic of care. Moreover, this perspective, which sees relationships as the primary interpretive key, will serve us well as we examine the healing relationship, which comprises the essence of the art of medicine. A reading where the focus is placed squarely on relationships, or lack thereof, among the characters in the parable, enhances the ethical force of the text's message. And why is this? Well, the reason behind a heightened engagement with the text when applying a relational hermeneutic stems from the attention given to the personal beings in the narrative. And by the use of the word personal here, I intend for us to stay focused on our being created in the image of God. Persons who are fundamentally, by nature, relational, as God is relational, right? Three persons, one in one being itself. In positing a reading focused on relational dynamics, then, I argue that a relational lens is not just another perspective upon which one might use in meditating upon the passage, but is in fact the central lens to employ primarily in minding the text for its application in the practice of medicine. Moreover, focusing in particular on the relationship between the Samaritan and the man who fell among robbers brings into sharper relief neighborliness as more deeply rooted in and constitutive of authentic Christian charity or agapeic love. And it is this agapeic love which arguably ought to constitute our care and concern for the patient. It is interesting to note that the first question posed by the lawyer, "What shall I do to inherit eternal life?" is not initially nor completely answered by Jesus' affirmation of the commandment to love God and neighbor. And perhaps the question by its nature focused on the questioner, as I was not the one Jesus answered, so to drive home in typical parabolic fashion the main point, which is about relationship with and to the other. Notice, however, it is the response to the corollary question posed by the lawyer, "And who is my neighbor?" that forms, in fact, an unassailable foundation for an ethic of care rooted in neighborliness. But before more deeply considering the healing relationship, two other points are important to bring to our reflection. The first is the matter of compassion. Etymologically, we recognize the word compassion meaning to suffer with another. The word itself presupposes relationship. Many times, with the use of the expression that we all know well of taking up one's cross, we think of our own suffering, what we're enduring, what has been placed upon our shoulders to bear. But I want to offer an alternate view, one that brings out or perhaps helps us to hone in closer to the meaning of compassion, entering into the suffering of another, to suffer with another. For example, while the diagnosis of a terminal illness or the heartbreaking sorrow over the death of a child or spouse is the experience of another, we may choose to suffer with the one who has that diagnosis or who is suffering that loss. Of course, the circumstances of the suffering are often not the same, yet we can place ourselves in a frame of mind, so to say, that precipitates a feeling within us, within our hearts, of emotional, visceral pain, which we can harness and join in a mysterious way to the suffering of Christ. In other words, there's an active dimension to compassion. It involves a decision to experience the suffering with another, not simply acknowledging it or simply understanding it. Thinking of compassion in this way is useful, not merely as a matter of understanding what it is, but of actually becoming more truly compassionate. In this way, we suffer not as the primary subject of the suffering, but we suffer nonetheless with another who is suffering as the primary subject. Jesus in his passion no doubt was the sufferer, but we might see him also as the compassionate sufferer. In his suffering, he is also sharing our suffering. He is suffering with us. He is a compassionate sufferer. We might even say a sufferer suffering with another sufferer. Likewise, in the healing relationship, we may become ourselves compassionate sufferers, taking on suffering that otherwise does not befall us. So, to be compassionate in this more nuanced and arguably more profound sense may be an ideal to which we in the healthcare profession should strive. And I contend that if so, the basis, or better yet, the only way to attain this deeper, abiding quality of compassion is to be firmly established in relationship, which of course for the physician and other practitioners of the art of medicine is the healing relationship with the patient, the primary sufferer. Now, building upon the neighborliness or relational dimension of this Lucan parable and showing how compassion is an integral component of the healing relationship, there's another foundational element which imparts a dynamism to the healing relationship. And this feature concerns the radical identity of the persons in the relationship. So I invite us to think about the who we are as healthcare professionals and who our patients are. Let's return again to the parable, and in doing so again, see the parable not so much as a teaching about ethics, about what to do, but rather how to be. The point here is not one of nuanced exegesis, but of reflecting upon the mysterious reality of being a child of God, of being created in his image and likeness. Often when I think of us being created in the image of God, I recall a Trappist monk on retreat once in Spencer, Mass, using the metaphor of a mosaic and how the face or image of God might be like a mosaic composed of innumerable tile pieces, of which are each and every human being that ever has been and will be created. I find this metaphor helps me to better grasp the reality that each of us is created in God's image, not in some generic sense as if God is the archetype and we're simply like products coming off an assembly line, but that we're unique, unrepeatable, and incommunicable creations of God, our Father. This reality is essential to recognizing the inherent dignity of each and every human being, and especially our patients, when it can sometimes be difficult to do so. And as we know, yet to more strongly emphasize this point, being made in God's image means that we are relational, made to be in relationships. Now, back to the parable. And who is my neighbor? The law professor asks, not how should I treat others? With this question, the parable not only takes us on a path ending with the ethical imperative to love, especially another for whom we might not otherwise care, but also provides us a clue as to the essence of the art of medicine, the healing relationship. While we identify a few of the relationships within this parable, Jesus and the lawyer, the man who fell victim, and the priest, the man and the Levite, we might agree that the primary relationship is that of the man who fell victim and the Samaritan. Surmising the neighbor to be the man who fell victim, in a parabolic twist, Jesus is posing his final question to the lawyer: which of these three do you think proved neighbor to the man? Anticipates the lawyer's response, announcing neighborly identity as the one who showed mercy on him, therein revealing the decisive point of the parable. We see the neighbor is not the man who fell victim, but the one who showed mercy. The Samaritan is the neighbor. That's the twist. But wait, there's more. While this ending rejoinder between Jesus and the lawyer reveals the Samaritan as the neighbor to the man who fell victim, the best answer to the neighbor's identity question, the man who fell victim indeed is also the neighbor to the Samaritan, given the nature of relational affinity. This is the key to healing relationships. Mindful of seeing the Samaritan and the man made for relationships, and the theological, if you will, anthropologic basis for that assertion, not only is the reversal of expectations revealed by the lawyer's response, the one who showed mercy on him, but the nature of neighborliness is more richly displayed. In other words, the neighbor is the one who gives, not only receives. the one moved at a visceral level by another's suffering and shows compassion, and the one who imitates divine mercy through sustained care of the other. Luke, in this parable, artfully offers us way more than a story of how to act ethically towards others, even others for whom one may not particularly care. The one who showed mercy, who himself experienced visceral, compassionate, self-giving, agapic love for the man who fell victim, is the neighbor who models authentic Christian charity, the one who is close by the man, who came close to where he was, who did not pass by on the other side like the priest and Levite, entered into a relationship with him which became the necessary condition enabling him to be neighbor. In his depiction of the man who fell victim, Luke conveys the extreme neediness of the man and the warrant for the Samaritan's actions. Further, in contrasting the Samaritan man relationship with the non-relationships of the priest and the Levite to the man, the extent to which opportunities for agapeic conduct occur deepens the understanding of authentic Christian charity. Further, contrasting this approach with a perspective that simply regards the actions of the Samaritan toward the man who fell victim may result in assessing the relationship dynamic between the two as unidirectional, in the sense that the one who shows care for the one who is victim or who is suffering satisfies the ethical conduct and thus reveals the point of the parable. However, a view presented by a relational perspective may make more readily apparent the bidirectional nature proper to any authentic relationship, where in the case of a caregiver-sufferer relationship, the nature of suffering itself elicits the formation of relationship. It's not just the caregiver who acts upon the sufferer, but the sufferer too, in a sense, in, through, and because of his suffering state, acts upon the prospective caregiver to elicit a response. I'll come back to this in a little bit later. This dimension may go unrealized when focus remains on the ethical conduct alone and fails to consider the interpersonal connectedness of relationships. So reading Luke 10:25-37, therefore, with a perspective centered primarily on relationships and secondarily with a lens to appreciate the other dimensions of the parable, opens a wider vista for us to reflect and meditate upon the depth and richness of Christian charity, particularly in association to the mystery of downtroddenness and suffering. Though we typically see the parable as an instruction on how to show compassion, especially to one who is ill or injured, and correctly so, this parable is obviously more than a first aid manual. It opens for us a perspective to realize the centrality of relationship animated by compassion because of our identity. I invite us now to leave the arena of scriptural exegesis and turn our attention to some current trends in clinical medicine. I want to make a few points contending that a loss, or at least the weakening of the healing relationship in medicine, is occurring. Why is this happening, and what is some of the evidence for it? These are good questions, and maybe if we have time in a Q&A, can discuss this further. I've spoken elsewhere about a crisis of identity and the lethality of forgetting who we are as sons and daughters of God our Father. And as I reflected upon this, it makes sense that to the extent that there is a loss of understanding of who one truly is, that is, that there's an identity crisis, so too then a loss of relationship will follow. A few years ago, I came across an article in JAMA which resonated with my misgivings over the increasing use of the word provider for physicians and other healthcare professionals, akin to the use of the term client when referring to a patient. Thankfully, this latter term hasn't seemed to catch on. It was heartening to me to read other authors take issue with the term provider. In another paper, the authors noted that, quote, the word provider comes from the world of commerce and delivery of commoditized services. It makes no reference to professionalism or to trusted therapeutic relationships. The personalized, important nature of healthcare depends on trust and professionalism, with the expectation that clinicians will place the needs of those they serve ahead of their own and those of their organizations. When used to designate those who care for patients, provider has the potential to suggest that patients are mere consumers, serviced without commitment to professionalism. This could foster distrust in the healthcare delivery system. End quote. In other words, in an insidious way, use of the term, as the argument goes, tends towards diminishing trust in the healing relationship and weakening the professional ethic necessary to it. As a physician who not only works closely and greatly respects other, quote, providers, I can attest to these concerns. In my consideration for the use of this term, I prefer to especially emphasize the professionalism proper to one's particular training and expertise, and I avoid using such a non-specific term. Along similar lines, fellow CME physician member James Breen, in his new book, Benedict Medicine, A Catholic Response to Rescue the Profession's Healing Mission, at one point employs a molecular biology metaphor of how plasmids, you may remember plasmids in your micro training classes, self-replicating strands of DNA that, when inserted into a host cell, alter the cell's DNA's composition. So he writes of novel definitions and neologisms as linguistic plasmids, fundamentally altering or rewiring perceptions of commonly held ideas and shared belief. And in the healthcare lexicon, the word provider leads to a deprofessionalization of the role of the physician. Now, in addition to deprofessionalization and changes in lexicon surrounding practitioners of the art of medicine, a loss of trust in healthcare also points to a woundedness in the relationships patients seek, or at the very least deserve, from physicians and other practitioners. The moral center of the healing relationship, that is, the physician-patient relationship, is the promise made by the physician to the patient through a covenant of trust. Yet public trust in the healthcare system, for many reasons, has declined in recent years. One main dimension of this decline is the growing disconnect between what patients want and need and what they see and experience. It is a disconnect between a transparent and trustworthy system that treats patients as humans in need of care and what many perceive as an increasingly consolidated, profit-driven system that treats patients as consumers buying goods and services. One manifestation of this is a patient-physician relationship seen many times as more transactional than fiducial. The foundation for the healing relationship is trust. As trust is diminished, then so too is the stability of the relationship. Another example of the current healthcare system, which may be interpreted as having a weakening effect of the healing relationship, is the prevalence of telehealth platforms for delivering care. To highlight this point, one study examining the use of clinical video telehealth visits found that patients perceived providers were less attentive, they felt unheard, and felt neglected. Here again are data concerning relationships in healthcare which tend in a direction opposing compassionate care. Let's now turn our attention to a few comments about remedy. What might be paths to pursue or mechanisms for the restoration of relationship in the art of medicine? In addition to recognizing some of the things that may be weakening relationships and deciding what may be our response on a practical level, remedies for the ills of increasing dehumanization and the weakening and demise of healing relationships might broadly be viewed in these three categories of what is needed. First, ongoing formation of the healer. Second, the development and sustenance of moral communities of clinicians. Third, greater attention with intention to attend to the suffering component of every healing relationship. Formation of the healer is occurring in so many ways, and hopefully I'm making some small contribution to this evening. We all have no doubt our personal and maybe unique ways of ongoing formation as healers. A significant component, I suspect, overlaps with our faith and spiritual formation. Prayer, scripture, sacramental celebrations, and more comprise and fuel our growth as compassionate healers. Developing moral communities is the nature of this local guild and of many other guilds of the CMA. Indeed, the CMA itself at the national level and many other groups and organizations promoting and defending the dignity of the human person are key ingredients of remedy for the anti-life, commodification, and other forces of assault to human dignity. Growing and sustaining these communities rooted in truth and love is a huge mechanism for recovering the goals of medicine. Along these lines of moral communities, another example is what, again, Dr. Breen is doing in South Florida in creating what he calls a Benedict Medicine Consortium, whose mission is to promote primary care ordered toward the growth of thriving Christian communities through support and encouragement of physicians practicing in accord with the principles of Catholic social teaching. Lastly, with regard to attending to compassion in the healing relationship, I offer these reflections derived from one of my best friend's saints. Pope St. John Paul II taught us much about suffering, and we will do well not only to know suffering, which I think is inevitable, but to know about suffering. And this is one of my favorite quotes from our late pontiff. Suffering is also present, he says, in order to unleash love in the human person. I'm convinced that we will be much more compassionate healers as we know and interiorize suffering. In my work as a pulmonologist and critical care physician, I've found what he taught us about requests for euthanasia to be very useful. Though I've only had a few requests for physician-assisted suicide over the past few years, Thankfully, because it is not legalized in our state, I always recall this quote from Evangelium Vitae. The request which arises from the human part in the supreme confrontation with suffering and death is above all a request for companionship, sympathy, and support. JP2, also in what would become known as the theology of the body, spoke of each and every embodied person being a gift to another. He spoke of the spousal meaning of the body, or the body's capacity for expressing love and self-gift. In the context of the art of medicine, I suggest that a healing relationship manifests self-donation in at least two ways. One, the patient allows him or herself to be cared for by the physician, and in so doing is giving the physician his vulnerability and an opportunity for service. And second, the physician making a true gift of him or herself through his kindness, healing touch, gentle words, and use of his knowledge to benefit the patient. About this relationship, we can further say that a communion of persons is formed. Finally, we all have our personal styles and ways of meaningfully engaging in healing relationships with our patients. Here are some recent examples from my practice. This beautiful man, a courageous and faithful Muslim who I was privileged to know and care for through diagnoses of severe COPD, coronary disease, post-cardiac arrest, lung cancer, to develop eventual oligometastatic disease for which he had an adrenalectomy and was able to visit again his home country of Morocco after that, having done well for a few more years, ultimately succumbed to recurrence of cancer in his lung with lymphangitic spread and profound hypoxemic respiratory failure. This was my saying goodbye to him the afternoon before the night he died. Another patient I've come to know because of reverse evangelization, I say. She came to see me as a new patient wearing a shirt that I immediately recognized as apparel from The Chosen, if any of you are familiar with that series. And my commenting about that led to a whole conversation about our shared like of the series. On a subsequent visit, she shared with me her excitement at having been selected as an extra for an episode of the series and shared with me these photos. This is her on the set of The Chosen and with other extras on break. And I especially like this one with her and Dallas Jacobs, although I'm not very fond of him these days after seeing the last episode recently. My wife can tell you how I blew up after something that occurred in one episode we saw. Anyway, we can talk about that later. Other patients, one patient saw me for interstitial lung disease, and who I especially connected with as his wife grew up next door to and whose family still owns horse farm land near another Trappist monastery in Gethsemane in Kentucky, where I had also been a few times on retreat. As I cared for him over the few years, his disease progressed, and he eventually underwent lung transplantation just about a year ago. And this is text messaging between us just prior to his discharge, after I had visited him in the hospital the weekend before his discharge. And this brings to mind something I want to mention I always do with my patient, and that is to share my work cell phone number. I recognize that it's hard for patients many times to reach someone when they're having a problem. The electronic medical record and patient portals notwithstanding. But it gives many patients, I find, a sense of peace an assurance that they can contact me if things really get rough for them. So I routinely share my number with them, and I think it helps build trust in addition to showing care and concern. Another patient, also with an interstitial lung disease, referred to me from New Jersey. His son on one occasion wanted a picture with me and his dad. I thought it was unusual, but I was honored to have it taken. So, what's the one word takeaway from this presentation? If it's a one word. Anyone? Relationships. It's all about relationships. Our primary relationship, the first relationship we ever had with God is with God, of course, with our family, our friends, and in this profession, our patients. Thank you for your attention.